Repeated movement testing is typically part 3 of my orthopedic evaluation. I don't use it with every single patient, but with nearly all of them. Part 1 is taking the verbal history, part 2 is taking the orthopedic baselines, i.e. mechanics. Now, if a patient presents to me with pain or complaints in the low back or anywhere down into the big toe, I might consider lumbar extension as a repeated movement test, meaning let's repeatedly move into lumbar extension and assess via cause and effect what's happening to complaints if they're there in the clinic and what's happening to the mechanical baselines we took in part 2. So lumbar extension is most commonly performed in standing or lying. If we're doing it in standing, typically the hands are placed on the pelvis for some support. But if the patient needs a bit more force or if the patient needs something for balance support, we can use a fulcrum. The chair in my office is about 39 inches in height, so it's great for most patients. I might have someone stand on something if the patient is shorter, but at home, most countertops are around 36 inches, so they can serve the purpose quite well, although patients use an array of things if we're testing at home. So over a fulcrum, you can see the benefit is typically we can get the patient further into the lumbar spine's end range of extension. So it looks kind of like this. Getting to end range, as we say, is where the magic happens. For a diagnosis of joint derangement, which is a specific diagnosis in contrast to, example, stenosis or degenerative changes in the back or a symptomatic spondylolisthesis, if I diagnose that the problem is a joint derangement and we can find a directional preference that fixes the problem, we want to get those joints all the way to end range, and adding a fulcrum and standing can really help us achieve that in many cases. We just need to progress that force when appropriate and when safe.